Okay, so now let's move on to castrate-resistant prostate cancer. Just this is a tough area, and fortunately, surgeons don't have to be involved quite as much here, but occasionally. But CRPC, back to precision medicine and testing. What are some of the challenges that we see? A lot of these surveys that we see nationwide and worldwide, just not enough testing, right? Whether it's germline testing. David, you want to talk to us about what the guidelines tells us about who should be tested and and what group should be tested?
Appreciate that. Germline testing for anyone with high risk the disease, even local risk disease, they should be having germline testing. Nodal disease, metastatic, to any type of metastatic prostate cancer should have germline testing. In regards to somatic testing, you typically metastatic disease or metastatic castrate-resistant prostate cancer we test. How many? Probably about 10% mutations across the board that we can identify that are germline related, with BRCA2 being the most common one. And we have a target called olaparib, that is eligible, patients could be eligible for in pairing with ARPIs. And so the testing is essential, I think, not necessarily for triple or doublet treatment, but certainly for that next line when they become castrate resistant, because all patients become castrate resistant because we're not curing them. So it's important to do the testing.
And between you and Dr. Gotti, do you guys like to test in the hormone sensitive setting?
Yeah,
Wait till castrate
I
resistant.
test at the very beginning. I test, and essentially, the patients coming to me again are refractory to other treatments. They're, if they're hormone sensitive, there may be targets there, and so like we're seeing, that RPFS positivity from amplitude with BRCA. So you may have a therapeutic target if that gets approved by the FDA. So you can use, olaparib earlier. Well, actually, in that case, I guess this was a trial of niraparib plus abiraterone for that amplitude trial. But in the castrate-resistant space, we've got 3 choices. So we've got abiraterone with either niraparib or olaparib, and then we've got talazoparib with enzalutamide. So these are the 3 FDA approvals in this space, and of course they have nuances about which groups they included in their final approvals. But we test at the beginning. We test germline. We usually test germline just once, right? You don't need to retest germline. There's not a lot of point there. But somatic we test along the way, and so even later down the line, if we think the disease is behaving not at all like a traditional, even CRPC, if there's a traditional to that, very low PSAs, we'll biopsy just to see is it's transformed to small cell or is it another aggressive variant prostate cancer.
It's also important to test for MSI as well. For, I rarely see it, maybe 2% are reported. Should they be a candidate for pembrolizumab, which is immunotherapy, they can have long durations of response. So
yeah, even TMB-high, so
correct.
Like we, I think probably a few of us have some experience and, I've had TMB-high guy of around 50, chain smoker, like still hasn't quit smoking, he's 80. He's done well. He's been on, over a year of immunotherapy and still, PSA close to 0. So how do you?
Yeah, it's just one of those things. I feel like we need to be an advocate for our patients, right? If you don't look, you won't find it. And we know that BRCA2,
Yeah.
PFS, RPFS, as is in the hormone sensitive setting, they progress quite quickly. It's a dismal disease. Looking for MSI-high, right, and ultra-high TMB, I can tell you a story about a patient of mine that was close to hospice, but we checked his genomics and he has a ultra-high TMB of 356.
Yeah.
The microsatellite stable.
Yeah. My patient 50, like I said,
Yeah.
he's still doing extremely well.
So you're a pembro, and I think he's cured of metastatic castrate-resistant prostate cancer and off therapy. We stopped it because of toxicity too, but you mentioned the Amplitude trial, right? So that was hot off of ASCO. Met its primary endpoint for RPFS, trend towards overall survival. So Is it ready for prime time yet? Looking at PARP inhibitors in the hormone sensitive?
Yeah, I mean, I think there's going to be proponents and people who are, cautiously moving into that space, right? So we always think about what is that risk of anemia. It looked like in Amplitude, I think it was 5 versus maybe close to 30% grade 3-4 anemia. So in the niraparib group, there was a much more significant anemia, and it did affect their life. It was a higher grade toxicity at that point. And then we also worry about MDS conversion, some of these patients who are on long-term PARP. So is that the right timing? I think, that will be anyone's question. But, we have a couple of these trials now that seem to actually be positive, even in some, not in this particular case, but even in some other ones, there were positive in some all-comer groups as well. And then the FDA sort of regulated it based on looking at the data in different subsets of the mutations. But we have some good-looking data in terms of, like I said, RPFS is a good accepted endpoint for these guys.
Yeah. So yeah, you alluded to the Propel study, the Magnitude study, and also TALAPRO-2. So 3 big options. One of them, TALAPRO-2, is for all HRR population. The other 2 are for a BRCA2 defined population. But good to have options, right?
Yeah.
And then we also have radioligand. We have lutetium PSMA. And then, we all think that radioligands is all about lutetium, but we forgot about our old friend radium-223,
Yeah.
which has now actually reemerged based on piece 3. Let's see, Nilesh, you want to talk about piece 3 and how that might fit into our current complicated paradigm that we're seeing?
Right. So radioligand therapy is another piece of the puzzle in terms of treatment for these metastatic castrate-resistant patients. We all may have heard about the original trial, Alisimca, looking at the benefit of radium-223 in those metastatic bone patients. The additional trials, ERA looked at abiraterone, but there was a higher risk of fractures with the incorporation of that. So there was a question whether, is this going to be a viable treatment? But the PEACE data looked at radium, but including bone preservation agents in that setting, and it looked like that mitigated the risk of skeletal fractures and improved the tolerability of for patients getting that drug therapy. But I will say that even though that data set is really good, with the advent of other radioligands, particularly Lutetium-177, the Radium-223 seems to be more of a niche setting now, maybe not as a forefront as Lutetium-177 for particularly PSMA positive disease. So I think just looking at the data, it seems like that's being more favored over Radium-223, or even though there are a subset of patients that could be a very good drug therapy for.
Yeah, so I mean, if you want to talk about the patient population for that, I mean, they excluded patients with visceral metastasis.
Yeah, exactly. I think that's the problem, right? We're talking about these now in the era of ultrasensitive images. You probably are more likely to find these visceral metastases and even find maybe a lot of excess nodes even in some patients, right? So I think they capped maybe a certain number of bone lesions in that trial as well. But I think the question always going to be, I think Pluvicto, I think, has another paired trial with another hormone agent, and people are going to decide still on which exact one they want to use between the two. Xofigo is calcimimetic, and it does like bony regions to where it exerts effect. I think in our classical view on the drug, pairing it with something is probably better and may get you more of that PSA response.
Right.
And then when you look at some of these trials and you see the amount of patients how they got there, in a lot of cases they didn't use prior ARPI. So is that our current patient population is the bigger answer? So a bigger question in this case is maybe in some of these trials 10% of patients were on ARPIs before. In the real world, we all know that number is going way up.
Mm-hmm.
In addition, I think for the first trial, the SYMPH trial was based on symptomatics, how symptomatic the patients and their bone mets were. And that's kind of what I think of when I think of Xofigo or Radium-223, when to apply it was in the symptoms. But with the new data, certainly comparing it with with the bone agent is helpful, but I think lutetium has more indications, well, given the wide use of PSMA, it's a great problem to have in terms of sequencing. How are we doing in terms of which agents to go? But I think the lutetium might be favored here.
Yeah, I think a lot of people, as you mentioned, is a calcium mimetic, and it doesn't really target the actual tumor. It targets the osteoclastic and osteoblastic activity, so the tumor microenvironment. So you don't really see a PSA response there, but you may see symptom improvement. You'll actually see improvement in alkaline phosphatase. That's another marker that we oftentimes overlook as well. So.
And I've seen that improvement, administering it for patients. Like I said, I think the challenge also has been a lot of the patients in the community setting, at least, a lot of the patients were heavily pretreated as well. They all had taxane-based chemotherapy, and so their tolerance for radium, was not the best. And I think a lot of these trials, and like you said, it's a good problem to have. We have so many agents. But the trick and the challenge is, what do you sequence? How do you start out for the meta-analysis? Which ARPI do you like to start as your doublet therapy? And so I think it's just going to take more data looking at incorporating these radioligands earlier with whatever treatment we pair with. And
that's a great point, right? Because we are moving radioligands up in this
Right.
space as well, right? So